Hello, Assalamu alaikum.
Hello, Assalamu alaikum.
Yeah.
Oh, finally.
Finally, we made it.
I did. I was like, maybe I'm in the wrong room or something. So both of us are here. Oh, IT has unmuted as well.
Mhm. Dr. Samia, where are you based in?
So I'm in England, in the Midlands,
Oh, okay.
Leicester.
Right.
Yes. And yourself?
I'm based in Islamabad and I'm at the Population Council.
Right. Islamabad is where my parents live.
Oh,
Hometown.
really? Wonderful. You studied in the UK all this while?
No, I graduated I did my MBBS from Rawalpindi Medical College.
Oh, really?
Yes.
When was that? Which year?
96.
96? Oh,
Graduated.
you graduated. Were you in 95 in fourth year?
No, we completed final year in 95 and our results sort of came on New Year's Eve. So some people classify us as the batch of 95, but more often 90. Hello?
Okay. I taught at RMC from 95 to 98. So I was just wondering.
Okay. What subject did you teach?
Community medicine.
Right. We had Dr. Fayaz at that
Yeah.
He took my vibe.
When he joined, I had left at that time, about to leave. Yeah. I think there was a overlap of a few months.
Right. Okay, cool.
Dr. Samia and Dr. Ali, can you hear us?
Yep.
Yes, we can hear you.
Can I just request kindly if you can mute your mics and we can just start the meeting formally in 1 minute. Thank you.
जी सर बताएं जल्दी बोलें सर जल्दी बोलें सर तो आईटी वाला तो बैठेगा तो नहीं ना सर आप प्रेजेंटेशन ऑन तो करें ना
Nine. Junaid, are we okay to start? Assalamu alaikum. A very warm welcome to our session this afternoon on 11th Public Health Conference at Health Services Academy. My name is Dr. Sadia Mustafa. I am Assistant Professor in Family Medicine Department here in Health Services Academy. I warmly welcome all of you to this session. The session title is Strengthening Healthcare System. A very broad title, but we'll try and have some useful discussions and we'll have your views this afternoon, try to find some policy guidance on that as well. Restructuring and strengthening healthcare system is obviously need of the hour. This weakness and gaps in the system have been more prominent in the wake of COVID pandemic. And it is need of the hour for us to start thinking about how best we can use our meager resources to strengthen our healthcare systems that is sustainable going forward as well. We are very lucky to have very eminent public health experts speaking on this occasion. Before we start, can I just outline the format of the session? The session will run until 4 p.m. The main outline is that we have got our guest speakers, our chairs, co-chairs that I'm going to introduce in a minute. And then we have got our keynote speaker followed by our presenters' presentations. After that, we will open the floor for discussion. We will have remarks from our chair and coach.
Sorry, we can't hear you.
Yeah, we've lost sound.
Hello.
Sorry. Okay.
Hello, now we can hear you.
Technical glitches beyond our control. Apologize for that. Right. So we were just outlining the session format. We have also got the session feedback forms on your desk. If you can kindly at the end, please fill in the feedback form that will help us improve our sessions in future. Can I please also ask you to follow COVID SOPs and keep your masks on? Obviously, I haven't got it on at the moment, but after that, I'm going to do that. So if we can kindly adhere to that, please. So the chair of our session is Professor Zafar Ali Chaudhry. I am not sure if he has arrived just as yet. He was traveling from Lahore and he was on motorway as when we last spoke, but we are expecting him shortly. Professor Saab is a professor of surgery, FCPS and FRCS from UK, and is currently a vice chancellor of Faisalabad Medical University. So we are hoping to welcome him shortly during the session. Along with that, we have got our co-chair, Dr. Shahida Asfar. Dr. Shahida is an eminent health professional and public health specialist of many decades of experience. She has worked as policy expert in various organizations like UNICEF, UNFPA, Family Association of Pakistan, and many others. Her service to field of public health are innumerable, and we are very lucky to have you here, Madam, today. Also joining us is our co-chair, Dr. Ali Mir, who is here online with us. Dr. Ali Mir is an associate at the Population Council and a senior director of programs and research at the Population Council Pakistan office. He's a medical doctor and holds an MPH from University of Leeds. He's completed several postgraduate trainings and courses and a faculty member of Health Services Academy. We are honored to have him online here with us today and looking forward to his comments towards the end of the session. We have also got Dr. Sadia Khan, who will have the role of discussant today. So after we have had our presentations, we will leave the floor to Dr. Sadia to facilitate the discussion on the topic. Dr. Sadia Khan is a family physician, MRCGP trained in UK, currently working as assistant professor of family medicine and leading family medicine department in health in RMU, Rawalpindi Medical University in Rawalpindi. So thank you, Dr. Sadia, for that. Starting our session formally, we have got the first presentation from our keynote speaker, Dr. Samia Latif, who has very kindly joined us from UK. Dr. Samia currently works as a consultant in communicable disease control at Public Health England. She's an assistant academic registrar for UK's Faculty of Public Health and a member of faculty's Global Health Committee. She also works in mental health, diversity and equality, and global violence prevention. Dr. Samia is a GP appraiser, an educational supervisor, and an accredited mentor. Her areas of interest are health protection, culturally intelligent leadership, global public health, and public mental health. Thank you very much, Dr. Samia, for being present today. You can start your presentation when you're ready. Thank you.
Assalamu alaikum, everyone. It's an honor and a pleasure to be here with you guys. I'm now going to see if technology works and share my screen. Oh, I can't share my screen, so I guess you guys are going to run the presentation for me. Am I right?
Let me just check. Dr. Samia, can you see your presentation now?
Yes, yes, I can see it. Are you able to go into the slideshow thing?
Junaid, slideshow pe kar dijiye. And you can tell us when to change the slide.
I will have to do that because I've been disabled to share my screen, so it'll work fine. Thank you, Sadia. Right. So as Sadia said, I'm a consultant in communicable and disease control. I'd just like to make a disclaimer here that any views or opinions that I present here are those are my own and not those of the organizations I represent. So basically, I was going to talk about the issues that we had in the rollout of the COVID vaccine during the pandemic, providing a UK perspective, and also the challenges we faced and how we overcame them. Now, I think the vaccination was central to the UK government's COVID-19 recovery strategy. And in order for us to return to normality, it was key that we had a vaccine available and we were able to roll it out. However, the success of any vaccination program depends on the rates of uptake among the population. And so here are a few of the things that we faced and how we overcame them. Next slide, please. If you could just click. And yes, okay. So, right. I was going to click through them turn by turn, but that's fine. Basically, vaccines are one of the single most cost-effective and clinically effective interventions known in public health after clean water. And they save lives every 5 minutes. And if a vaccine had not eradicated smallpox, we would now die from the disease every 6 seconds of every day. Yet millions of people worry that vaccines are a threat to themselves, to their children, to their loved ones, and such fears result in vaccination rates dropping. And we've seen that over the course of history. So right from 1976, or even just before that. So when Edward Jenner got the idea to use milder cowpox virus on a child and inoculate him to prevent smallpox, or slightly before that, it is believed that the Ottomans introduced the concept of variolation. There has been a backlash because people objected to it and people were driven away from their hometowns right back to the 18th century when the first shots were given. From the outset, vaccinations provoked skepticism and fear. In 1853, smallpox vaccine was made mandatory in Britain. However, opponents rejected it on religious grounds. They raised concerns over the dangers of injecting animal products and claimed that this would harm future generations. We go through 1885 when we had Louis Pasteur, who developed a vaccine against rabies, and that process also sparked mistrust. 1920s were the vaccine's heyday, actually, when we saw shots rolled out against tuberculosis, diphtheria, tetanus, pertussis. And that was actually, I think, the best period of time that we had. Then comes 1998, where we had the famous, or rather, should I say, infamous Andrew Wakefield study in 1998 that was published in the Lancet, which suggested a link between the MMR vaccine and autism. And that, to this day, we are facing, the adverse effects of that study, even though that study was withdrawn and disproven. But to this day in the UK and across other parts of the world, we do see people who believe those links to be true. And coming a bit nearer to home, I think the polio conspiracy theories are only too well known to people in Pakistan and Afghanistan, where it still is a scourge and remains to be eradicated due to anti-vaccine conspiracy theories. So these conspiracy theories have been there right from the start. And then we come to the concept of vaccine hesitancy. Now, vaccine hesitancy is the reluctance or refusal to vaccinate despite the availability of a vaccine or vaccine services. And so much so that WHO has named vaccine hesitancy as one of the top 10 international threats. Vaccine resistors or vaccine deniers take it to another level altogether. They just refuse vaccinations in general and deny the scientific consensus on the effectiveness and safety of vaccination. So we've got all of that happening in the background. And as I alluded to earlier, it's not just the vaccine, it's the whole process and the whole systems and policies that need to be put in place. And what we saw with COVID is that no one could be left behind. You leave one person behind, the rest of the community is not safe. A lot of effort was put into getting it right this time so that all members of the population were covered. And a vaccine equalities task force was created for this purpose. And for the first time, it was felt that years and decades of inequalities may be given a chance this time round, because everyone realized that you can't leave anyone behind with COVID. If we can go on to the next slide, please. So I've alluded to some of the issues that we've seen since vaccines have been invented, but just bear in mind that sometimes there is some collective history of malpractice, such as the Tuskegee study of untreated syphilis in the United States. And we've got loads of other examples where communities have been unfairly discriminated against. And that history lives in the subconscious of those communities. The issues we faced when rolling out the COVID vaccine across the UK sort of relied on how people perceived vaccines, what their past experiences were, how much they knew about the vaccine, and how they perceived either the risk of COVID or the importance of vaccination. So perception is really, really important, and what the subjective norms are, and whether any religious or moral convictions came into place. So in the UK, right from the start, in fact, even before the vaccine program was launched, a lot of the religious and faith groups got together and started talking about how they were going to address the issues amongst their communities. For example, the British Islamic Medical Association has got a great website, and they've got one of the best mythbusters I've seen on COVID vaccines. If you do get a chance, do look it up. So a lot of people got together, our Christian communities, our Sikh communities, our Buddhist communities all got together to see how they could work with their faith groups. And when we talk about perceptions of risk, what we noticed earlier on, so we've had a series of national surveys in the UK that have taken us from the start of the pandemic to this day, where public attitudes and fears and acceptance and beliefs towards the vaccines have been documented. And you can see the change in people's belief and people's attitudes. So right at the start, we knew that the younger population was a bit more averse to taking vaccines compared to the older population. We still see that the youth, as in the 10 to 19 years old or the 10 to 29-year-olds, have less uptake compared to the older age groups. And likewise, we had a huge inequality between our Black, Asian, and minority ethnic groups, so much so that the Black British groups were around about 40% unlikely to take the vaccine, and followed very closely by the Pakistani and Bangladeshi communities. And some of that perception was linked to how aware they were of COVID, how COVID was doing in their home countries. And because the UK had a head start in the pandemic with our increase in rates, and the rest of the countries were slower to follow, they believed that if things were okay back home, things were okay with them, they would not tune into the regular media channels. They would rather tune into, the Pakistani channels, Hum TV and Jio, and follow the news there rather than the BBC or the news channels here. So this we picked up really early on. And so a lot of work was done in imparting the information. And to be honest, when the vaccine came out, hubby and I are fortunate enough that we're health professionals and we could make an informed decision. We could read up about the vaccine and, put any concerns to bed. But for the general layman, for the general public, a lot of those concerns were very real. And you can't blame them. They were worried about side effects. They were worried about whether it causes infertility, and a lot of those concerns that I'm sure you must have faced and are still facing in Pakistan, as are we in this country. So you need to be able to provide that knowledge in the right way. So a lot of work was done. We can go on to the next slide. A lot of work was done around myth busting, around fake news, misinformation. And what we very quickly realized was that we were dealing with an infodemic within the pandemic. I mean, I'm sure you've all seen those WhatsApp messages, those conspiracy theories come up. And I think these two animations or cartoons really illustrate the point and bring it home. So we had to tackle that, and we had to tackle that as sensitively as we could, working with local communities to get the right message out there. If we could click on the next slide, but just click once, please. Once more. Thank you. So we did a really good piece of work with the Chief Medical Officer, where we got together all our Black, Asian, minority, ethnic health professional diaspora people, because approximately a quarter of the NHS workforce is from the Black, Asian, and minority ethnic population, as in they're from other countries or from or second generation. And so we did a great piece of work bringing these health networks together. These health networks were working over and above their day jobs to try and promote awareness around COVID and the vaccine. Next click. And we also published a study on this in the BMJ Leader. Next. And this is just an example of some of the work. So this work was done with members of the BAME communities in Bradford, where we have a huge Pakistani Mirpur diaspora community living. And we used a lot of behavioral science approaches as well to tackle the misbeliefs and the conspiracy theories. Next, please. And this book is actually predates COVID, but as I've alluded to, the vaccine issue has been an issue since time immemorial. Next click. I think one of the really positive campaigns that had an impact was sort of bringing the story back home and making it feel real for you. And if you could tell a story where you could see how, or people could see how COVID has impacted families, they were more likely to sort of agree that COVID was real and it wasn't a conspiracy theory. Next slide, please. So this is a really good infographic. At the time that we were battling with the pandemic, the Race Health Observatory was launched in the UK, and some of the key facilitators that they've alluded to, key, I think, is building trust. You've got to build trust with the population. If the vaccine is being delivered by people they're familiar with, people they know, people they trust, they could be healthcare professionals, they may not be healthcare professionals. And I think this is something we've realized over time. So you need to have them on board. You have to have your local community champions on board. You've got to have your local mosques, your local synagogues, your local Sikh temples, Gurdwaras and Hindu temples. You've got to have your local churches on board. So that is how we built trust. And a lot of the vaccine campaigns were launched through mosques and delivered in those settings that people were familiar with. And the other key take-home point for me personally has always been about the message. The message, the messenger, and the medium. You need to make it very clear. The message has to be simple. It has to be in a language people understand. And it has to be delivered by people they trust and through media that they trust. So we found in the UK that the older generation, for example, prefers face-to-face mediation. So a lot of campaigns have been done where people have knocked on doors, telephone calls have been made, or even using the younger generation where we have multi-generational household, we've used the younger generation to convey the message. And the message should have a story, frame the vaccination story within a narrative. And that really, really helps. And whereas social media has its dangers, it has its uses too. Repeat the message, be consistent, engage with your communities, and embed the vaccine delivery using familiar localities, and use an asset-based approach, and also use your health professionals, and then provide clear real-time data so people are aware of what's happening. These were some key things that we found that helped. And another thing that we discovered is we've got a few oral or spoken languages in the UK that are not really written, such as Sylheti or Pahari. And so we had to do a lot of work translating material and making videos, and people went around door to door with iPads so that they could show the videos and convey the message. So these have been some of our key facilitators. We are still working very hard to roll out the vaccine. And as you may have heard, the UK is now rolling it out to a younger age group. And with the younger age group, we face different issues. But in a nutshell, these are some of the issues we faced, and these are some of the approaches we found that have really helped. And my last slide is just some references.
Thank you very much, Dr. Samia, for a very enlightening presentation. If you have got time, we would ask you to be present for some time until we get to the end of presentations, and then we can have question answers and discussion, if that's okay.
That's absolutely fine. What I will do is I'll switch my video off so I can multitask in the background, and then I'll be around when you need me.
Yes, that's great. Thank you.
Thank you very much.
So moving on to our presentations, our first presenter is Dr. Babar Tasim Sheikh, who is a well-known name in public health. He's working as a director technical at JSI. He has expertise in health system dynamics, policy, management, administration, and strategic planning. We are very honored to have you, sir, here. If you would like to come and present your presentation. Thank you.
Bismillahirrahmanirrahim. It's a pleasure and honor and privilege at the same time to be at the Academy once again and at this forum, which has become a regular feature of the Academy, and also very important learning opportunity for the public health fraternity, especially the students and researchers. This conference is very opportune, has been organized at a very opportune time. And this time, as we all know, is marked with COVID-19 pandemic. I have been invited to speak on post-COVID-19 scenario. And since I am a health systems person, some of you know me, I will probably be focusing more on health system side and less on COVID. I am not a COVID expert. I'm not a virologist. I'm not a pandemic expert. So my presentation will be focusing, and these are very 7-8 slides, not a very long presentation. And I'll be talking about what we need to do in terms of when this pandemic is over, what we need to do in the health system of Pakistan. But it is important to understand the background. What happened when this pandemic came to Pakistan? February last year, if you all remember, this is a month and a year which will be remembered for long. And what happened? We all had most inadequate knowledge on this virus. Although this virus belonged to influenza family, but we had insufficient knowledge. We had no clue how this is being transmitted and what is its strength and power and virulence. What we adopted as an approach, and I give all credit to the government of Pakistan and the provincial governments who came on board at the very outset of this pandemic. And we were able to build a national consensus that we went into smart lockdowns. Instead of going countrywide lockdowns, we went into smaller hotspots, smart lockdowns. And today, the world has recognized that that was the best approach that was adopted. Looking at our economy, looking at our socio-cultural dynamics, looking at our segment of daily wages and the way people started facing hardships in their daily earnings, this was the right approach. But what happened to the health system? The outdoor patient services were shut down. The human resource working in the hospitals, they were not trained when the hospitals got flooded with the COVID patients. We had very limited finances as usual. You know, those of you who have been my students, health system of Pakistan has been getting meager finances. And besides that, there was no emergency fund available. There was no contingency plan with the Ministry of Health and the departments of health. And we were also short of supplies. That included a simple surgical mask, which you are all wearing right now. We had to even import this surgical mask, as simple as that. What to talk about the bigger ventilators, which were badly needed at that times. So overall health system response was suboptimal. Suboptimal means that it was not par excellence as it should have been in case of any pandemic. And it was very timely realized that for addressing the challenge of this pandemic, we need a national, concerted, unified response, and not the single provinces can make their own strategies. So what I'm going to show you today is what I researched a little bit. And I have used WHO's health system building blocks to capture the state of affairs which we encountered. And then on each of these blocks, on your left hand, these are the health system building blocks, the 6 blocks. And I am going to show you 6 slides. On each of the block, what was the problem that we encountered? And I'm going to give you a very crisp way forward. You may or may not agree, that's your prerogative. And that is going to be the premise of my presentation. So 6 building blocks. Can we go to the next slide, please? So first block is the governance. What happened to the governance when this pandemic outbreak happened? We took some time to decide who is in the driving seat, federal government or each of the provincial government. And as I said, we were fortunate to constitute under the leadership of Premier of this country, NCOC, जिसका dashboard आप रोज देखते हैं. And we were able to build the national consensus that this is going to be a national approach. Whatever decision is taken in Islamabad is going to trickle down to the provinces. And that's a good omen, basically. Despite the 18th Amendment, when provinces enjoy their autonomy in terms of administrating and in terms of financing healthcare, it was a good omen. Right away, there was a federation, province coordination and communication mechanism was built. Political will was on the top. It was very clear that the national leadership wants to address this pandemic in a serious manner. And the provincial leaderships were shoulder to shoulder with them. So the timely decision making helped in putting things together, pulling resources together, and deploying whatever we had, strategies and resources throughout the country in a timely fashion. So this is the key, mind you. In a country where the systems are devolved, where the health systems is fragmented, this is the key, how to put your governance in order when there is a public health threat of this scale. Next, please. What happened when we started looking for some money? As we all know, the overall kitty of the health is very small in Pakistan. And we have been underspending in health historically. And whatever we have got in terms of budget for health, as a student of public health, I have been keeping an eye, and you should also keep an eye, how this budget is spent. And we all know that a big proportion of this budget is skewed towards non-development expenditure. Then debate came about what should be put in by the federal government and what should be put in by the provincial government when we need to strategize for this pandemic. And it was suddenly revealed on us that the millions of dollars which we are planning for, government won't be able to do it alone. Even if the provinces join hand, it won't be possible. So the development partners were called in and the donors were called in. And this was again a very prompt action that a kitty was created and finances were pooled, and then procurement started of the essential supplies which were needed. And that is, I say, again, a very important building block of health system, that whenever a public health threat, a pandemic or any epidemic of this scale comes up, financing has to be arranged very quickly. And the lesson learned from this threat is that we should have an emergency fund available for such threats, because the times which are coming, these kind of new infections keep on emerging and keep on resurging. Next, please. The next block that I'm going to talk about is the human resource. And as we all know, human resource are the backbone of the health system. So the staff working in the tertiary hospitals, and the tertiary hospitals were the most who were receiving the COVID patients. Some of the secondary hospitals and mostly the tertiary hospitals. Do they have the training to treat and attend infectious disease patients? Very rare. Do we have specialized departments in the hospitals who deal with infectious diseases? Rare. This is my personal observation and experience. So we need to work on that. Do we have enough numbers of people who have somewhat capacity to deal with infectious diseases? We need to work on these numbers. How these human resource in the health sector who have got the right training, where are they? Again, the data shows that they are mostly posted and appointed and deployed in the larger urban centers, larger metropolitans. What about the peri-urban areas and rural areas? Because this infection has started hitting the rural areas after a few months. Do they have the competency in some basic epidemiology and infection prevention? Because what we see that doctors and paramedics, after some time, they started facing casualties themselves. And we lost many friends who were doctors and who were nurses while they were attending COVID patients. So this is another area which I would like to flag that we need to work on in the future. Use of personal protective equipment was a very basic thing, but we had to arrange trainings throughout country on donning and doffing, how to put on the personal protective equipment and how to put it off once your duty is off. And then this new era of international health regulations and global health security agenda, we need to impart this new set of skills to our human resource who are working in the health systems. Not only the doctors who are working in the hospitals, I would rather emphasize more this training more for the managers and their supervisors. We need to impart this special set of skills. Next, please. Now, next building block. Pandemic is here. Do we have the medicines? Do we have the supplies? And do we have the logistics? When we looked at the stock of medicines, it was limited. We looked at the number of hospitals beds available for these COVID patients. They were limited. When we look at the availability of isolation wards and high dependency units, seldom found in any tertiary and teaching hospital. They had to create and arrange these isolation wards and high dependency units to cater to this number of patients who are coming. Do we have enough oxygen in this country? Again, there was a shortage which was faced. Do we have enough number of ventilators? And this was the first time in my 26-27 years experience, Dr. Shahida, that we came to know that Pakistan के पास सिर्फ 1500 ventilators थे जब COVID आया. सिर्फ 1500 जो काम कर रहे थे. So we had to work on it on emergency basis. दुनिया में ventilators नहीं मिल रहे थे, खरीदने के लिए भी कोई नहीं available था. So we asked our Science and Technology Ministry that we should start local manufacturing, and then few departments have actually embarked upon this manufacturing, and now we have, alhamdulillah, enough number of. I have already talked about we had to import masks and sanitizers. There was no inventory system from where I can get the information. Tomorrow, how many supplies I will have, and in 1 week's time, how many supplies I will have, and when do the next procurement happens. There's no inventory system. There's no formal inventory system in health. So this is another need which this pandemic has shown to us. What is the system of procurement? PEPRA. PEPRA. Those of you who work in the government sector, you know this is procurement rules of the government through which you have to go for the procurement. Those PEPRA rules were set aside because it was a public health emergency, and we had to go for an emergency procurement in the region and globally. So those rules had to be set aside, and this flexibility should be there always in any health system. Vaccines, as you know, no vaccine was available, and then a shortage of vaccine all over the world, and still there are countries who are competing on the vaccines which are now being manufactured all over the world. So again, we have to be on our feet, and now we know that NIH has taken an initiative and local vaccines are now being made available. Information, this kind of dashboard, we never had it, but it's a good sign that we have a dashboard of this kind. Now we daily see the statistics rolling over on this dashboard, and this dashboard is important instrument. कल जो लोग यहाँ इस कमरे में थे, I had the same remark. Dashboards are fine. They look very fancy. They look very attractive, colorful. But for God's sake, let's build the capacity of our managers on how to use the information which is displayed here. Let's do the advocacy with the policymakers, how to make use of this information for decision making. This is again another lesson this pandemic. Well, पहले भी पता था हमें, नहीं use करते ये लोग information, but this is what this pandemic has shown to us. बनाएं ऐसे dashboard, but इस resource को use भी करें for decision making. Service delivery. Now this again pandemic has shown, जिसको हो जाए उसको तो चले अल्लाह करे, जो ट्रीटमेंट हम दे सकते थे दे रहे हैं, बट प्रिवेंशन, इस कौम ने पहली बार सीखा सही तरीके से हाथ धोना. लेट्स ऑल एक्नॉलेज दिस. हम सब पैदाइशी मुसलमान हैं, बस पहली बार इस कौम ने सीखा सही तरीका क्या है हाथ धोने का. सो दिस इज what is public health, and I am glad many of my family members now know what I do. और आप में से भी जो पब्लिक हेल्थ वाले लोग जो अपनी फैमिली को नहीं बता पाते कि पब्लिक हेल्थ में करते क्या हो तुम लोग, बताओ उनको अब जाकर क्या करते हैं. What service delivery needs is structural changes. आपका primary system should be geared towards prevention, which is its actual role. Your secondary and tertiary healthcare system should have isolation wards, should have quarantines, should have high dependency units and ICU staff trained in using the ventilators. We had to develop, conduct, organize these trainings throughout the country to train people who work in the ICU. वहाँ का staff को, doctors को, paramedics को ventilator नहीं चलाना आता था. मरीज आया, ट्यूब लगाई, 100% oxygen खोल दी. You know what 100% oxygen does? It burns your alveoli. And at one point in time, I called state minister, the then state minister. मैंने कहा सर कोविड से नहीं लोग मर रहे ICU में, वेंटिलेटर्स की मिसमैनेजमेंट से मर रहे हैं. Don't quote me on that. And then we trained people in ICU across the country, 55 bigger hospitals across the provinces. I trained people how to manage cases on ventilators, especially the COVID cases. Public-private healthcare utilization, we keep an eye on that. Quality of care is questionable on both sides. Government may be questionable hai, private sector may be questionable hai. I'm not going to go into that debate. We all know that. SOPs for infection prevention and control for the hospital, for the patient, but for the healthcare provider also. मुझे भी मेरी सेफ्टी अजीज है ना, मैं भी खिदमतगार जरूर हूँ इस हेल्थ केयर सिस्टम का, लेकिन मैंने जिंदा रहना है तो खिदमत करूंगा ना. So this is what was needed, and unfortunately we lost many friends treating COVID patients. And community health workers, again you have a force available of community health workers, lady health workers. They need to be trained. I'm sorry, उनका जो curriculum है वो भारी से भारी होता जा रहा है, but these new infections coming up, there are some important 4 or 5 messages which only these community health workers can go door to door and give it to the community, and they have really worked. And this is probably my last slide. I'll be done. So what are the lessons learned? इस pandemic से हमने क्या सीखना है? हमने सीखना है we need good governance, and in this devolved system of health we need interprovincial harmony. Political will, alhamdulillah, is there. This needs to keep up. We need to increase the fiscal space for health. We need more money to deal with these kind of threats. We need to invest in our human resources who are working in the health sector. We need to create an inventory management system so that we know that in the pandemic times, in the epidemic times, what kind of stocks do we have? We should know that. We should create these fancy, beautiful dashboards, but we should promote how to use this information for decision making. And we must tailor our service delivery in the local context. And we must customize our service delivery to deal with these new infections emerging and resurging every now and then now, looking at and keeping in concentration in our system-wide values. Thank you for your attention. I'm done.
Dr. Babar, thank you very much for your valuable insight and sharing your experiences with us. Our next speaker is Professor Hassan Abbas Zahir Saab. Dr. Saab is a PhD in hematology and has worked previously as professor and head of pathology in PIMS. He is currently working as WHO advisor on blood safety and has worked closely with Government of Pakistan as a pioneer and manager of Safe Transfusion Program. Thank you very much for coming today for your talk, sir.
Thank you very much. I'm very grateful to the conference organizers for inviting me and providing me an opportunity to talk about the blood safety systems reforms in Pakistan, which we implemented from 2010 until last year. And I had the honor and privilege of pioneering this reform process and leading it until last year. Next slide. So in this presentation, I will briefly talk about the pre-reforms blood scenario in the country, which also persists to quite an extent currently also, and what we did in the reforms process and the achievements of the project in terms of infrastructure and technical development, and some key highlights of this project and the way forward. So, in Pakistan, we have a demand-driven fragmented blood transfusion system in which the need of the blood arises first, and then we start looking around for blood donors. And invariably, it has to be the friends and family members of the patients who are provided, who come forward as blood donors. And on the basis of these family and friend members, the whole system works. We collect about 3 million blood donations every year from about 650 blood banks. But there are also a lot of undocumented blood banks which are functioning from miscellaneous settings like doctors, clinics, pharmacies, grocery stores, and all kinds of weird places. A lot of blood, we have to admit that a lot of blood is not used rationally, and it is also pilferaged, especially from the large public sector hospitals in the country. And in many cases, the blood banks, even in the public sector, they are not managed by professionals. And the technicians who are working there are mostly people who have learned their job. They've learned their work on the job. So the quality of work of blood that is available, again, voluntary donors are the best kind of donors. They are available to a limited extent. So the next best is family donors. So not the best quality of blood is available. And because there is shortage of blood, so we rely on taking blood directly instead of doing pre-screening of the blood. A lot of blood banks are still using manual screening kits, which are very substandard, cheap, and not registered and not properly accredited. And as a result, in our blood donor population, we get a lot of cases of hepatitis B, C, and HIV, and much more cases go undetected because the kits that we are using are substandard and they are not good enough to pick the infections. And the processing of the blood, the testing of the blood, the immunohematology, that is also quite weak. Blood grouping is not done properly, and cross-matching is, I would say, not done in all the blood banks, let's say. And even where there is cross-matching, it's not done properly in most of the cases. Transfusion reactions are mostly not documented because the blood banks have no real linkage between the bedside where the blood is transfused and the blood bank itself. So what is happening is that, or it was happening to a large extent until the reforms, was that in all the hospitals we have small blood banks, 2-3 room department of blood bank, which is collecting blood from voluntary donors or family friend members, processing the blood for component preparation, doing screening of the blood, other processing, storing it, and then compatibility testing, and then issuing it. And this is happening in this blood bank hospital, this blood bank hospital, and this blood bank hospital. And I'll give you the example of Islamabad. We used to have 22 licensed blood banks in Islamabad, and all of them were doing all of these things, which means duplication 22 times over, which is such a waste of resources, and quality also suffers. So what was happening was that there was suboptimal utilization of resources and duplication of resources, and screening standards were poor. And as a result, people's lives were being put at risk, and there was a lot of wastage of blood also. Yeah. So in 2008, the government decided to fix this situation and try to reform the blood transfusion system. And the German government offered technical and financial support to fix the blood system in the country. But no one in the health department or the health ministry knew how to go about it. So they placed this responsibility into the hands of the National AIDS Control Program, because that was the only department which was doing something related to blood, which was just a provision of screening kits to some blood banks. So for a long time, this offer, which started actually in 2004, went unutilized, but finally the reforms started in 2008. And for 2 years, we worked and this was the time when I joined the AIDS Control Program, and we started actual concrete work on the reforms process. We developed a consensus to have a centrally coordinated blood transfusion system in the country like the rest of the world. Developed PC1s for all the provinces separately, got them approved in 2010, and then started implementation of the project. And at the same time, the basic concept was to build a new infrastructure of modern blood centers all over the country, and at the same time do technical work to prepare the system to man the new blood centers according to the international recommendations. So the first phase of the project was completed in 2016 when we developed 10 modern blood centers all over the country and renovated and upgraded 60 blood banks. So 70 centers were covered in the first phase. All of these are fully functional now and providing excellent service to the people in their region. And we are now nearing the completion of the second phase of the project, in which the size and scope of the project has been expanded and more centers have been built and upgraded and renovated. So this is the model that we worked on. The international recommendations are that the blood production should be separate and blood utilization should be separate in two separate places. So what we were doing previously was that we were producing blood and utilizing it from the same small blood banks in each small, large, and medium-sized hospitals. So through this project, we started on this new concept where we would have these large regional blood centers which would serve as the blood production site, and their function would be to collect blood from voluntary donors and others also, prepare the blood components, other processing, blood screening, storage of blood, and then transport the prepared blood component to the hospital-based blood banks and stop them from doing all this work which they were doing earlier. And so the reformed role of the hospital-based blood banks was to receive the prepared blood components, store them, and issue them to the patients as and when required. So these are the 10 modern blood centers that we built all over the country, starting from Gilgit right up to Karachi, and they're all functional now. And each of these blood center is linked to 6 existing blood banks which are renovated through this project. And the German government through KfW supported not only the construction of these blood centers, but also their equipment and furnishing and also trainings. And these are pictures from 2016 when one after the other, these new blood centers were completed and inaugurated in high-profile ceremonies where the political leadership and the German partners were there, and everyone is very happy looking forward to the functioning of these projects. So in the meantime, while the infrastructure was being developed, we were also preparing the system to man these new infrastructure according to the modern international guidelines and practices. And we did a lot of work. I will briefly go through these technical achievements, and you can share this presentation if you want further details. And I'll start with the most important thing we did was to develop and to do a lot of work on policy development. We did this at the national level, included blood safety as a priority area in the National Health Vision for the first time. And we also contributed very significantly in the policy work at the regional level from the WHO platform. And all this work was documented at the same time. It's available hopefully somewhere on the website. On the basis of this policy, we reviewed and revised the legislation and strengthened the regulatory system. Also, we don't have a single legislation on blood safety in the country. Every province and region has its own legislation, which is not uniform or comprehensive. And so we thought that it is good to have a single uniform updated legislation, and 3 provinces have already adopted these legislations. Again, all this work was documented and is available somewhere. Blood regulation is very important. You can have very good service delivery, but if it is not regulated properly, there's a big problem. So we had blood transfusion regulatory authorities in all the provinces and regions, but they were there for a very long time, but they were not properly operational. So we did a lot of technical work and developed some manuals and guidelines about how to rejuvenate the regulatory sector. And the best example of this was the Islamabad Blood Transfusion Authority, which was revived by us in 2013. And we were successful in developing an excellent model of regulation of the blood transfusion sector, which we tried to replicate in the provinces also by working with our counterparts. This Islamabad model of blood regulation was quoted by WHO as a model for the regional countries also. Sadly, the government disbanded this authority 2 years ago and amalgamated it into Islamabad Health Regulatory Authority, and this process is still not complete. So the system is unregulated in Islamabad for the last 2 years. Voluntary blood donation is the backbone or the foundation of any blood system, because this provides the raw material for the whole work. And if you don't have the good quality raw material, and no matter how much effort and money you put in, you will never get the desired results. So we did a lot of work to promote voluntary blood donation in the country. And the most important of this was working with the social media giant Facebook to promote voluntary blood donation. They got in touch with us about 3-4 years back, and they came to us with a feature that they have developed for 3 countries, basically, including Pakistan. And their idea was to help people who need blood and connect them with the people who can donate blood. And so they were very happy to share this tool with us. And we were horrified to look at this tool, because this was in complete disregard of the international recommendations and guidelines and bypassing all the safety features. So gradually we were able to convince them that what they had put together with very good intentions was not really what is required. So over a period of 2 years or so, they became convinced and reformed their system. And we presented this experience 2 years ago in Switzerland in a blood transfusion conference also. And now this feature with the help of the Pakistan Blood Program, is being used in many countries of the world very successfully, and especially during the COVID pandemic. We did a lot of work to build the capacity of the people working in blood banks, because this was a very, very neglected sector. Blood transfusion was not even recognized as an entity. It was just considered part of the pathology department. So again, a lot of documents were produced. A lot of people participated in producing these documents with us, and trainings were done. But long-term solution is to have a proper curriculum on transfusion medicine, and we developed this document also, which covers training needs for the doctors, nurses, and technicians. And we involved a lot of national experts for developing this curriculum, and also the relevant national organizations like HEC, PMDC, and CPSP, and others. Quality culture is absolutely missing in the country, and it is absolutely non-existent in the blood sector. So we try to change the mindset of the people working in this sector, again, through a lot of trainings and developing a lot of these technical documents. And there are many blood centers now who are using actually these documents and improving their day-to-day quality systems. When the infrastructure became ready in 2016, we realized that our clinicians still had a habit of, they weren't practicing rational use of blood. In fact, they were practicing completely irrational use of blood. Whole blood prescription was widespread. And so we had to work a lot with these clinicians, especially gynecologists, and we engaged with them in dialogues all over the country in different cities, especially where the RBCs were located, and tried to change their prescription practices. This is something which needs to be done repeatedly, and until last year we were doing it. Again, a lot of technical documents were produced, and they're still available. All the new infrastructure that we have developed, we developed a customized MIS system for that, and it is being used in those places. And a lot of other private and public sector blood banks are also switching over to computerized systems. Prior to the establishment of the program in 2010, there was hardly any research publications coming out from Pakistan. But now, gradually, we have started churning out publications regularly in high impact journals also, and you can Google and find that out. During this time, a lot of experts visited Pakistan to provide technical support, and these are very big names in the transfusion world, and they are not only very impressed meeting the experts in the country, but have also conveyed to the rest of the transfusion world about the exciting developments happening here. Again, some of the technical documents produced, a lot of activities and a lot of appreciation from the national leadership and the German partners. We participated in a lot of international conferences all over the world, and a lot of people in the transfusion sector are following our progress. And these are all the large blood transfusion partners, and we are working very closely with all of them to implement these reforms. This work was covered a lot in the media. For the first time in the country, we collected blood transfusion, blood banking data in a scientific, methodical manner, and also published it. Worked with WHO also. They also provided us very useful technical assistance. And until last year, we had a very good communication system. We've used to bring out monthly newsletters. We were very active on the social media and annual reports and everything. June 14 is the World Blood Donor Day, which was celebrated in a big way all over the country. You can see a lot of people very happily participating in all these activities. And as a result of all this hard work, the Safe Blood Transfusion Program became the national platform and national voice of blood safety, not only for Pakistan, but also at the international level. So this is our current footprint. You can see we have presence all over the country in the form of these large blood centers. This is the most important success, I think, of the program, public-private partnership. in the province of Punjab and Sindh, the blood infrastructure that we have developed is being managed by the private sector. And some of these, especially by the Indus Health Network, they're working on the international standards. It's really very impressive. If you happen to go to Multan, Bahalpur, Jamshor, or Sakar, do visit these centers. The way forward is that German support is going to come to an end at the end of the year. And since my departure from the program last year, there have been frequent changes and the reform momentum is not there anymore. So the government needs to do something to put the program back on track. My suggestion is that the program may be twinned with a dynamic health sector organization like the Health Services Academy to ensure that the reform process continues uninterrupted even after the departure of the German partners. And I will conclude my presentation by sharing with you the best kept secret in Islamabad. And this is the Regional Blood Center in Islamabad, which is just a stone's throw away from this place. And this building has been ready for the last many months. Sadly, it is not operational yet. I would invite you to go and visit this center on your way back home. When you hit the main road, take a left turn. After 2 minutes, take another left turn in the jungle, and you'll find this beautiful building there. Thank you very much.
Thank you very much, Dr. Our next presentation is being presented by two presenters, Dr. Amna Khan, who is a medical graduate with an MPhil in public health. She's working as a senior project coordinator in AKU Digital Health and Resource Center. And after that, it will be Dr. Momina Muzammil, who will be presenting the part of the presentation. She is involved in monitoring, evaluation, research, and learning at AKU Digital Health Center. So Dr. Amna Khan, if you want to kick off, thank you. Just like to remind you, we just pressed for time as well, but very welcome to you. Thank you so much.
Assalamu alaikum and a very good afternoon. I'm Dr. Amna Khan. I'm representing Aga Khan University Digital Health Resource Center. I, along with my colleague, Dr. Momina Muzammil, we are going to present some of our work which really worked during the pandemic. So I'm not going to take a lot of time. I'll keep it crisp and short. Next slide, please. So I'm going to tell you what Aga Khan Digital Health does actually. We do the research, innovation, technical support, technology development, and access to ICTs, which are in alignment with the SDGs 3, 4, 5, 9, 10, and 17. Just brief overview of our work. We are widely spread in Asia and Africa, and in South Central Asia, our work is widely spread in Pakistan, Afghanistan, Tajikistan, and Kyrgyz Republic. We have our footprint in East Africa, where we work in Kenya and Tanzania. I'm just going to walk you through our digital health connections in South Central Asia. We have a lot of hospitals, CHCs, diagnostic centers, BHCs, and BHU, which during the pandemic, we linked through teleconsultations and mobile applications, which really worked wonders for us. And this is our footprint in East Africa, Kenya, Tanzania, and Uganda. So we all know that the South Central Asia and the East Africa, we all face a similar sort of challenges in health systems. That is, there is gaps in health information system, it's poverty, and then the COVID-19 pandemic, underdeveloped health system, security hardships and conflict-ridden, like the situation in Afghanistan and Syria now, it's like really conflict-ridden, and then we have a weakened human resources. So these all challenges are across, similar across South Central Asia and East Africa. What worked for us are the 3 mobile applications. You can download it from Google App Stores. These are the 3 mobile applications which were under COVID-19 Innovation and Research Project. We called it SERP. There were 3 mobile applications. Number 1, Corona Check. Number 2, Virtual Doc, teleconsultations. Everyone is very well aware of it now. In Pakistan, it's called Ilaj Asan, and in Nairobi and Kenya, we call it Pigya Daktari. We have the third mobile application, which is PPE mobile application, which is for healthcare workers and frontline workers, in which they can see the videos, which are WHO approved videos, and then they can see, how to use the PPE in resource constrained areas. SERP project is in line with the Sustainable Development Goals 3, 4, 9, 10, and 17, as I already mentioned. So we are in alignment with the SDGs. We used two research methodologies, qualitative and quantitative. Qualitative through focus group discussions and key informant interviews. On the second side, we used the quantitative measures, which was through the data collected through the mobile applications. So we talked about Corona Check, Virtual Doc, PEMA. Corona Check and Virtual Doc, they aim to strengthen the health systems. I'm going to show you the UI of Corona Check. It's a mobile application. You download it from Google Play Store. It's a self-assessment tool. Here we have displayed the UI. So you have a assessment form. It has been translated into Urdu as well. And it gives you, it decreases the burden on the hospitals by providing you safe information that whether you should visit the hospital or not. And then in case you need to visit the hospital, the application refers you to visit your nearest facilities. Also to reduce the vaccine hesitancy, we have a lot of videos which are incorporated within the application. Next is the Virtual Doc teleconsultations. It's an application actually, which is for the time being, we are only using at Aga Khan centers. It is known as Ilaj Asan in Pakistan, and we have linked our doctors, gynecologists, pediatricians, orthopedics, and surgeons through a through teleconsultation. So a patient book an appointment, the doctor is present anywhere in the world, and they get the they book the patient, they register it, and the patient have the consultation online. So thus reducing the burden of patients on the hospitals. The same system is known as Pegya Daktari in Nairobi and Kenya. It is working efficiently in Kenya and Nairobi. Next is the application, mobile application, which we call PEMA. It's a PPE mobile application where you see a lot of videos on how to use PPE in a resource constrained countries. So it has a lot of videos, and the healthcare workers can go through videos and see how to use personal protective equipment effectively. Now I would like to call upon Dr. Momina, who will be talking about our next mobile application, Hayat.
Thank you, Amna. Thank you, everyone. Can you hear me? Okay, great. So I'm here to talk about Hayat. It's one of our digital health interventions. It was implemented in select areas of Gilgit-Baltistan as well as KP. And the reason we're here to we're discussing it is because Hayat is one of the first digital health tools that was actually adopted by the government. So the Department of Health in Gilgit as well as in KP, they've decided to take over the operational cost for Hayat starting 2021. And we're just here to give you a brief overview of what the implementation process was, what the intervention is, and what we think really worked, because there's always this hesitancy when it comes to implementing ICTs in remote areas, but we're seeing that there's actually still a lot of benefit to get out of it. So Hayat basically started off as a mobile app that was provided to lady health workers and vaccinators. And what we did was we digitized whatever forms that they were using into a mobile app. So it contains all those forms regarding registries and records of MNCH services, as well as the reports that they generally carry. In addition, we also added a stock management module. We added awareness videos, which were quite a success. So instead of face-to-face sessions, they were now providing evidence-based material through videos. And the app also has an offline capacity because we know there are communication challenges there. So we can sync data through SMS technologies when there's limited internet connectivity. And the data from these mobile apps gets synchronized into a centralized web portal or a monitoring dashboard, which was developed for government workers, policymakers, as well as the supervisory staff of these health workers. So these are the UIs of what Hayat looks like for a lady health worker. And it was developed in local language, and we conducted lots of training sessions to build their capacity. So Hayat basically used a quasi-experimental study design, and we saw that there was a significant improvement across multiple MNCH indicators, vaccination indicators, as well as satisfaction of services of LSWs. The first column, the second column, actually, it shows the percentage difference between the baseline and end-line survey. But we also did a difference in difference approach, which basically accounts for the confounding factors or the confounding variables that were present, such as disruption of services during the pandemic. So for example, we see that there was a 12.1% decrease in exclusive breastfeeding. However, because the pandemic hit and we saw that there were a lot of myths regarding breastfeeding and people were actually hesitant to do it. But when we see the difference in difference, we see that there's almost a 16% improvement between the control and intervention sites. And we believe that this effect is solely due to Hayat. We also did a qualitative assessment, which was done at midline to further refine the scope of the intervention, and then it was done at endline to see, to understand the user experiences and see the impact. So we saw that there was an improved tracking of children who were to be vaccinated and defaulters. So basically, whenever there's a child due for vaccination, the lady health worker or the vaccinator, they get a notification. It allowed enhanced coordination with supervisors, particularly during the pandemic. The user-friendly interface was easy to use. The availability of data informed decision-making, which was very valuable. We also saw that the community experienced an enhanced awareness regarding multiple MNCH topics. And the health workers, they reported feeling more empowered. They said that communities take us more seriously now, and we also feel more comfortable discussing things that are otherwise taboo, such as family planning. These are just two testimonials. I'm just going to skim past them because of shortness of time. So overall, we saw that Hayat allowed integration between different programs. Previously, MNCH was being delivered in silos, which I understand is a problem everywhere. But what we did was, so now we allowed horizontal integration between the MNCH program and the Lady Health Worker program. It allowed close to real-time monitoring. Previously, supervisors had to wait for the end of the month to get a monthly report, whereas now they could just collect, they could just get data whenever required. It strengthened the transparency and accountability mechanisms due to GPS tracking, as well as monitoring the attendance of health workers. We saw a significant improvement in contact and continuous coverage. There was a larger demand for services, such as family planning products. There was a higher utilization of services, such as deliveries in health facilities. And similarly, there was availability of data to inform decision-making. So what we think really worked in Hayat is early and continuous stakeholder engagement. So we worked with Lady Health Worker Program, Department of Health, as well as EPI and other offices to make sure that whatever we were designing was in line with their priorities. The design of the intervention was made in close collaboration with the end users, and there was a huge focus on the end goal, which was health system strengthening. So we see that initially when we started off with the project, our scope was limited to vaccinators and lady health workers, but because it's a holistic thing that we have to look at, so there was vertical expansion as well of the program. So we also included their supervisors, as well as community midwives, DHVs, TSVs, so as to complete the entire picture. That's about it. I'm sorry for taking so much time. If you have any questions, we look forward to receiving them. Thank you.
Thank you so much, AKU team, for your presentation. In the schedule, we have got Dr. Sobia Naeem, who was meant to present online, but we have she here. Can we just check? Unmute kar de. Dr. Sobia, are you online and can you hear us? Dr. Sobia, if you are online, can you please start organizing your presentation, and we will just move to our next presenter and then come back to you. Our next presenter is Dr. Ataur Rahman. Dr. Sahab, are you here in the hall? Dr. Ataur Rahman? Dr. Ataur Rahman? Dr. Sobia Naeem, can you unmute yourself, please? Can you hear us? No, Dr. Ataur Rahman. Right, I think we are unable to connect with Dr. Sobia. I'm not sure if she's around. We are nearly towards the end of the session as well. May I request Dr. Sadia Khan to please take the podium and facilitate, or yeah, from your seat. If you can just facilitate maybe another 5-10 minutes of discussion across the table. And then we would like brief comments from our co-chair present here and online, if that's okay. So maybe just brief 5-10 minutes discussion. Thank you.
Hello. Yeah. Thank you, Dr. Sadia Mustafa, for the scientific sessions. So, Bismillah Rahman Rahim. We had a very excellent, comprehensive presentations from our esteemed presenters. So, is Dr. Samia Latif here?
Yes, I am.
Okay, Dr. Samia Latif, you can hear us.
Yep.
Great. So, we began with Dr. Samia Latif's presentation on COVID-19 vaccination and take-up of COVID-19 vaccination hesitancy, as well as vaccination refusal and denial. So I was very glad to hear the historical perspective that you began with, because it is not only limited to the COVID-19 vaccinations, but it has been historically, the same phenomena has been repeating over time. So if you have any questions from Dr. Samia Latif's presentation, we can have the question answer session. Yeah. Okay. Right. So if you have any comments from the audience, please, you can have your comments. Please introduce yourself and.
My name is Dr. Umair. I'm working in National AIDS Control Program as a treatment specialist across Pakistan. My question is Dr. Professor Zahid Saab. Since he left, I think the whole momentum is halt. What was the plans with German government to establish regional blood banks in Pakistan? And till date, how many are functional? Sorry, will you be? But how many, I need the numbers. How many, what was the plan if there was 20 are completed in phase 1?
Five new drug centers have been completed and 20 have been completed, but the new
since you left, is there any program manager at the blood safety program? Because I think a finance guy is heading a national blood transfusion authority. Because they have advertised the position and they are confused about the public health and the hematologist. I need your suggestion, because minister was asking me, what do you think? The ministry is confused. This program should be head by a hematologist or a public health person. They don't know, I'm sorry. Since you was the national program manager for HIV, and then you were the lead force behind the blood transfusion program in Pakistan. I know we were together. What I saw is there is screening at every blood bank for HIV, Hep B and Hep C, at least on papers. But the clients who are HIV positive, they are turned back and they refuse for the donation. But there is no proper follow-up mechanism. If there is central MIS, like in COVID testing, we have Chughtai and public-private airport, whoever is testing, the record is going to the NCOC. Can we have a mechanism where every HIV, even false positive, is linked to the HIV program, so that we can confirm them, link them, and test their spouses and children? Thank you, sir. Thank you, sir.
Sorry, moving on to Dr. Babar Sheikh's presentation on strengthening building blocks and strengthening health system, configuring post-COVID-19 scenario in Pakistan. So Dr. Babar gave a very comprehensive presentation on how we face the challenge of COVID-19 in Pakistan and how the government of Pakistan took some very challenging, faced the challenge of COVID-19 pandemic and took leadership and showed some prompt responses. But initially, we faced grave shortages and deficiencies and in our health setup. So we lost a lot of precious lives of our young doctors who were at the forefront of managing the COVID-19 patients due to perhaps lack of PPE, not enough knowledge, not enough training. And he really made very spot on recommendations as well. So thank you, Dr. Babar Sheikh, for coming up with all the facts and figures and providing us with the in-depth ground realities of when we face the COVID-19 situation. But thankfully, miraculously, Pakistan has come out from that challenge quite gracefully, thankfully. So if there is any question regarding his presentation, please welcome. Sir, please introduce yourself first and your organization.
Sir, across the Pakistan, थैलेसीमिया के पेशेंट्स है वो बड़े नीडेड होते हैं ब्लड के लिए, उनके लिए मेरे ख्याल में किसी भी डिस्ट्रिक्ट लेवल पे या डिवीजन लेवल पे कोई ब्लड का कोई प्रॉपर अरेंज नहीं है। और अकॉर्डिंग टू माय ओपिनियन कि मैंने देखा है कि बहुत से बच्चे सने बलूगत में जब आते हैं तो तब उनकी जो है वो डेथ हो जाती है। तो आपके पूरे पेपर में पढ़ा उस सिलसिले में आपने कोई ऐसी सजेशन नहीं दी या कोई इसका कोई प्रोग्राम नहीं बताया कि उनके लिए हमारी क्या जो है स्टेप्स आपने लिए।
No, I had a question from Dr. Babar Sheikh regarding his presentation. That was about the countrywide lockdown versus smart lockdown policy. And I think that successfully managed the COVID challenge. So please, could you just elaborate on that? How did you reach that conclusion? Where did the idea come from, and how successful you feel that the idea has been? And has anybody else learned from our idea and taken it forward?
If has anybody else or any other country has learned this, but as we are progressing with this pandemic, every day there is a new bit of knowledge about COVID-19 and how to cope with this pandemic. But ye hai ke the statistics shows and the way we have kept our economy going, of course, this smart lockdown approach was the right approach. A country where 60% population lives below the poverty line, a good number of people who are daily wagers, and also a country which is facing a high level of inflation and unemployment in the youth segment. I think this was the right approach to use the smart dashboard and to identify the hotspots and to put the lockdown on in those hotspots instead of putting the whole country in a lockdown situation when your economy comes to a total halt, and that we could not actually afford to do that. Today, the way we have recorded our statistics of COVID-19, I think we have shown it to the world that this was the approach that has worked, and other countries, also developing countries with challenging economies and challenging socio-cultural and socio-economic dynamics and situation in their countries. I think they should also make use of intelligent use of information available, and they should go for smart lockdowns until and unless they have some other circumstances and determinants which are their own country specific, which compel them to go for a complete lockdown. I think smart lockdown was the right strategy.
Thank you very much. I'm pleased to hear that we have come a long way from having 1,500 ventilators at the time when the COVID started to now hopefully inventing our own and creating our own ventilators. So that's kind of the journey that has been a steep learning curve. So if there is any question regarding Dr. Babar's presentation, please ask that question.
I have. Dr. Babar, आपने कहा कि Dr. Babar, sorry, आपने कहा कि doctors ने fight किया and we have lost very precious life. I have a suggestion, if you can ask the ministry and we can make a policy that every healthcare cover, especially the doctor, must have a life insurance and health insurance, because we are the front line. It's not the mask. I have the risk of my family, and so the disease is here at least for 2-3 years, it looks like. So we can talk to the ministry and we can initiate a dialogue for life insurance and health insurance. I don't have a health insurance with me.
I would also congratulate Dr. Zahir for coming up with blood transfusion reforms in Pakistan, which were much needed over a long period of time. It was indeed an area that deserves attention for over a long time. And when the patient needs blood transfusion, he is in a critical stage of life-threatening emergency after a blood loss situation as a result of injury, fracture, post-operative or per-operative complications. So definitely improving the standards of blood transfusion and ensuring a safe blood transfusion program was a much needed area that was prioritized. Coming back to the third presentation by Dr. Amna Khan and Dr. Momina Muzammil. So this is an example of a successful project which was keeping the role of digitalization in strengthening health system. And they have used mobile applications, Hayat and SERP, which is the COVID-19 Innovation and Research Project, successfully in many different countries, including Pakistan, Afghanistan, Syria, Tanzania, Kenya. So if there is any question regarding this project, please do ask, because I think this project is something very new for us. We grew up in an era where mobile phone wasn't available. So using a mobile phone application in a rural setting where there are midwives and people who don't even know English, they don't even know Urdu, I think it looks like a very innovative idea to me. So I definitely have a lot of questions, but I'll keep those questions to myself and ask the audience if they want to ask some questions.
Treating
I've seen that model, but the beauty of our project is that we work for the communities which are most vulnerable communities. When I say vulnerable communities, we talk about the remote BSCs in Gilgit, Skardu, and Chitral. So what we do is we provide them with the internet connections, and then we make sure that our basic elements for our tertiary care health offices are linked with those BSCs.
this is a healthcare model. That is a home care model. So you are linking the BHU and RHCs, private or public, with AKU. My question is another model is different. We need to discuss, we need to explore, because they are not here. This was my suggestion. Thank you very much.
Dr. Mazhar Kasad, if you can be very brief now, हाँ जी बताइए.
सुनी? तो कहीं भी आपने आजकल जो कंफ्यूजन फैला रहे हैं, हाँ सर, और मिसअंडरस्टैंडिंग फैला रहे हैं कि भाई ये जो वैक्सीन करा रहे हैं 2 साल के बाद मर जाएंगे, या इसके इतने इतने साइड इफेक्ट्स हैं, या जो है वो आप पॉपुलेशन डिक्रीज कर रहे हैं, उनमें कोई नहीं रहेगी, बस खत्म हो जाएगी पॉपुलेशन बढ़ना. इस पे आप थोड़ा हमें बताएं कि क्या है ये लोगों की जो मिसअंडरस्टैंडिंग है, कंफ्यूजन फैला रहे हैं उनके बारे में.
आप ठीक कह रहे हैं. ये जो प्रेजेंटेशन थी ये तो बुनियादी तौर पे हेल्थ सिस्टम के ऊपर थी. आपका एक और सतून जो है रियासत का वो मीडिया है. तो ये बहरहाल उसका एक वाइटल रोल मौजूद है मीडिया का, और कम्युनिकेशन से रिलेटेड जितने भी स्टेक होल्डर्स हैं कि मास लेवल पर मास अवेयरनेस कैसे फैलाई जाए और कैसे इंक्रीज की जाए और इम्प्रूव की जाए, और लोगों की ये जो मिथ्स और मिसकंसेप्शंस हैं इनको कैसे दूर किया जाए. काफ़ी हद तक कामयाबी रही भी है इसमें, लेकिन ये होता काफ़ी चैलेंजिंग है, बिकॉज दिस इज़ टू डील विद ह्यूमन बिहेवियर्स. और आपने और हमने पोलियो के सिलसिले में देख लिया है जो हमने किया है, हमें कितने साल लगे हैं इस चैलेंज को ओवरकम करने में. और इस तरह की और बहुत सारी दूसरे टैबूज जो हमारे मुआशरे में रहे हैं. टीबी फॉर इंस्टेंस आज भी एक टैबू है, HIV एड्स आज भी एक टैबू है, और इस तरह की और बहुत सारी चीज़ें. मैं मैडम ख़त्म कर लूँ अपना कमेंट, फिर आप ज़रूर बोलिए. तो इसमें बहरहाल गवर्नमेंट की तरफ से भी और NIH जो इसका फोरफ्रंट ड्राइवर था, उन्होंने बहुत सारे किताबचे और ब्रोशर्स भी पब्लिश किए हैं. लेकिन ज़ाहिर है लिटरेसी इतनी नहीं है हमारे मुल्क में, इसलिए हमने इलेक्ट्रॉनिक मीडिया का इस्तेमाल किया है. और अब जैसे आपने सुना होगा टेलीफोन पाकिस्तान टेलीकम्युनिकेशन अथॉरिटी ने रिंगटोन्स के ज़रिए भी बहुत मैसेजेस आवाम को देने शुरू किए हुए हैं. तो आहिस्ता आहिस्ता विद द पैसेज ऑफ टाइम हालात में बेहतरी आ रही है. लेकिन आपका कमेंट ठीक है, ये टाइम टेकिंग प्रोसेस होता है. माइंडसेट्स को चेंज करना, ह्यूमन बिहेवियर्स को चेंज करना, ये एक रात में नहीं हो जाता. आपने ठीक पॉइंट उठाया. जी मैडम.
बहुत शुक्रिया डॉक्टर बाबर. वी आर रियली प्रेस्ड फॉर टाइम, सो अनफॉर्चुनेटली we'll have to wind up now. If we can, I think we really have to wind up. My apologies. If we can, Acha, thank you. If we can take some comments from Dr. Ali Mir, who has been patiently listening to us online. Doctor, if you can just give us your comments or any observations
before we finish, we'll be grateful. Thank you. If you can unmute yourself.
Ji, thank you very much, Dr. Saba, for giving me this opportunity to not only be, I'm sorry I'm not present physically, but I have to come through the virtual medium. But I think that this is also one of the positives that have developed as a result of the COVID phenomena, that we are now using the virtual world more than we were using it in the past. So thank you very much for organizing this session on health system strengthening. It is indeed for Pakistan, health system strengthening is definitely a very important priority, and especially when we consider that we did not achieve the Millennium Development Goals, and now we are just 8 years away from the Sustainable Development Goal targets. So we can't, find ourselves after 8 years again among the pool of countries that failed to achieve the SDGs, and especially since countries in the region with more modest and meager resources like Bangladesh, Nepal, and Sri Lanka were able to achieve the MDGs. So we can't lose this opportunity. I've been hearing, with great interest, the presentations that were made, and I think that almost all of them covered some areas of the health system and health system strengthening. Just for the sake of clarifications, and I'll just go into a little bit more, elaboration on some of the points that I want to make, that we must understand that health system strengthening definitely goes beyond those interventions which are designed to fill gaps and achieve short-term outcomes. Health system strengthening includes those efforts that bring about a permanent change in the system to make it work better. So that's why I was interested to hear Dr. Hassan Zahid when he spoke about the way he has been able to transform the whole blood bank system in the country. But I was also a little perturbed at the end when he said that his move from that position is going to jeopardize the whole system. So I think that the important lesson is that we must, right at the beginning, when we are investing in system strengthening, we must consider elements of sustainability, because otherwise the whole initiative gets jeopardized. Another point that Dr. Babar made about using the 6 building block model to explain to us the COVID response that Pakistan successfully was able to embark. I think he rightly pointed out that I think that the most important lesson was that there was a political will. And so when we talk about health system strengthening, also I think that the fact that we have had up till now a weak health system is because we did not have the kind of political will or priority to the health system in the past. So I think the timely decisions taken by the political leadership was extremely important. And as he explained also, that if we are talking about bringing an improvement in the health system, finances are key. And that's what we learned from the COVID response. And another point which he underscored, and I totally agree with, is the need for bringing about structural reforms in the manner we do things, in the manner we collect data, in the manner we utilize data, in the manner we train our personnel, the manner we utilize our personnel. I think that all this managerial structural reforms definitely are needed to bring about a change in the manner of things, how we have been doing up till now and what we should be doing. Another point that again comes with health system strengthening, and which I think Dr. Babar and Dr. Hassan Zahid also mentioned, was about quality and the lack of quality culture in our country, and the lack of training of especially of our providers in quality of care. I think that is something which is extremely important as well. Another point then again, which relates to health system strengthening in the context of Pakistan, is that we have a huge private sector. And I think that we need to develop better partnerships with this huge private sector, which has a huge infrastructure available. But at the same time, it's very important that the public-private partnership should be based on a sure footing and also be governed by very good stewardship and regulations. Because although the private sector, as I said, has a much larger outlay and a much larger infrastructure, but so long as it is unable to provide care to the entire population, issues of equity will remain, and lack of equity is an extremely important impediment in providing access to care to all the citizens. And since we are talking about SDGs and we are talking about SDG 3 and universal access, we cannot omit or exclude the reaching out to the poor. I think that I was really impressed by the presentation that was made by colleagues from AKU. And I would say that I was impressed because from the 6 building blocks that Dr. Babar mentioned, the WHO building blocks, I think most of these blocks were taken into consideration while developing these apps. And I think that one of the most crucial and important one is that when you're designing a program or designing an intervention, taking into consideration the end users who are going to benefit from the program. So community participation, one of the criticisms of the 6 building blocks of the WHO has been that community participation does not appear more prominently. And so community participation is required while we plan, community participation is required while we implement, and community participation is also required while we for purposes of accountability. And another good point good feature that we saw in this in the AKU example of using mobile technology, I would say one of the other pluses of the COVID epidemic has, as I said, it has propelled us into the 21st century, especially in terms of the use of mHealth, mobile health. The good point of this is that we have, for many years, we have been talking about health systems, information systems, the MIS, which is so poor, the way it is collected, the way it is analyzed, the lack of capacity to analyze is the issues of quality of the data that we are collecting, and above all, the inability to utilize that data in any way in monitoring performance or in decision making. But I think that use of mHealth, M technology can obviate many of these impediments that were there in the past, because we can now get real-time data and which can help in in decision making quickly. And another aspect of this is of self-care, because when we talk about health systems do not imply simply the availability of infrastructure. Health system goes beyond that. It includes the home care which is being provided within the homes by a mother to her child. It includes again the use of mass media to influence and change behaviors. And that's a point that I picked up from the keynote speaker, Dr. Sima's excellent presentation of how mass media was, or the media was used in the United Kingdom to change especially behaviors or influence behaviors. This for us as part of in strengthening health systems, we should also be looking at the judicious use of the media, and especially now that we have got electronic media, social media, because there are so many myths and misconceptions that still abound, that have contributed to some of our health problems, especially in terms of accessing healthcare. We saw that also happening at the time of COVID, when people thought that if you had the COVID symptoms and you went to a health facility, they will put your entire household into some sort of a house arrest, or sometimes there's misconceptions that they might give you an injection to increase the number of deaths related to COVID. And so many, myths were abounding. There are so many myths that still persist, or were there very much so, but now have really successfully been abated as a result of mass media use with regards to polio, but then there are still with regards to family planning. So use of mass media to change influence behaviors is very much a part of health system. And in the same way, Babar was mentioning about washing hands, I think that environmental sanitation and cleanliness is again something which is part of the health system approach. So COVID has taught us many lessons. We are continuously learning about the weaknesses of our health system. While I would say that the health system showed a great deal of resilience, but having said that, I would also say that it also brought out certain weaknesses in our health system, especially in terms of the morbidities and mortalities that were seen in terms of maternal morbidities and mortalities, and also infant mortalities and morbidities, which were picked up by none other tertiary care facilities and in major cities, where we saw that OPDs were closed and routine services were being denied, antenatal care had stopped, population welfare facilities have stopped functioning. So that again has had a toll on the lives of mothers and children. So while at this time, while we celebrate success in overcoming the epidemic, it also brings to fore certain weaknesses that need to be taken into consideration. So
Dr.
having
Meir,
said that,
Dr. Meir,
I would
thank
like
you
to
so
end.
much for your observations. Thank you so much.
Okay.
My fewest apologies to cutting you short there. Grateful for your observations. We just have to wind up the session if that's okay with you.
Thank you very much. Yeah, I'd
So
like
much.
to just I'd like to end over here. And I would say that it was a pleasure being here. Thank you very much.
Thank you, Dr. Saab. I would just take some final comments from Dr. Shahida. I'll be grateful for your comments. Thank you. Your Honor.
Session, presentations, and the comments of the discussions with Dr. Ali Meir. What I would just like, I have very few points. One, I would like to say that I think this topic is extremely important. Health system strengthening, because this is like the foundation of any house. Unless the foundation is strong, any structure you built on it cannot take on additional structures, especially emergency like earthquakes and things, unless the foundation is strong. So I think this is something that we have to build into, keep it constantly in mind. Secondly, I think most of our programs end up by being vertical or disease-oriented or donor-driven. When there is a project with a donor fund, like we've seen in the case of the blood bank, excellent initiative, done very well. May die, I hope not, but it is difficult to sustain it once the donor funding stops, because it's not part of the system. I think that's the second. The third point I want to make is that this pandemic has given us a wake-up call to assess whether our systems are robust enough to take care of any emerging issues that we are not aware of. Well, in this case, the world was not aware of it. It's not just us, but I think it gave us, as Dr. Baba rightly pointed out, that we had certain shortcomings before we were not prepared, and that's not just us, it's the world. So I think the 6th point for me, I think was a very good thing for the look at these issues regularly. So we look at health system strengthening in good times and in bad times. In the sense that when something happens, it has to be, the system has to be not vertical, isolated, fragmented approaches. And lastly, I think what Dr. Samia found out about changing behaviors, I think is very important. We are still living with the same issues that we faced. We are still facing it because people are not convinced that this is really a disease that will take that we have long-term effects. We don't know about it, not because vaccines were developed so fast that people are not aware of what. I think mass media is very important. It's not sufficient. I think we keep forgetting that our culture is universal. Listen to your neighbor, your trusted opinion leader, whether it's an imam or whether it's a mother-in-law or whatever, and we've not used the interpersonal communication, especially the lady health workers who are in constant contact with the women and the families, to give this message how important it is. We are still facing problems with polio, and we will continue to face problems with this pandemic. And the issue is, we have to very so I think just let's not focus on one people, but include in the curriculum of all levels of health, and include all the training that Dr. Baba mentioned on use of ventilators, whatever that is.
Thank you. Thank you so much. With this, we conclude our session. We will just have now the certificate presentation ceremony. Dr. Shada, if you can kindly present the certificates to the participants. Participants, please. If we can just move the chair. The Professor Sir. Please take the pictures. Abhi, thank you. Sorry. Yeah. आवा खान की चीज से डॉक्टर आमना आइए 2 सर्टिफिकेट लीजिए
Everyone, please join us for a group picture.
Dr. Ali, if you're online, sorry we are missing you at this ceremony. Aapki hum shield or certificate, we will send it to you.